If you're having hemodialysis through a dialysis access, either a fistula or a graft, you need to know what are the problems that can arise and how you deal with these problems. Because of course, if you have end-stage renal disease or renal failure, the dialysis access is your lifeline. So in this video, I'm going to explain everything you need to know and everything bad that can happen with this dialysis access. And most importantly, how can we fix them using minimally invasive procedures? So let's first do a quick review. So there are three types of access that can be used for hemodialysis. The first one is a catheter, is a tunnel catheter that can be inserted in the neck or in the chest that can be used for the dialysis. It's not the preferred method because catheters can get infected, you can develop sepsis, and also they can damage the internal vein. So we prefer not to use catheters long term. Second, you have an arteriovenous fistula, which is usually a surgical connection between an artery and your normal vein, and that's the preferred method. It's usually in your arm, and they can last a long time, and they will never get infected, essentially, because it's your own body. The third method is a graft, which is a synthetic tube connecting an artery to a vein. It's a plastic tube that then can be accessed during dialysis. It's better than a catheter, but they have more problems than a natural vein. Like I mentioned before, there are several problems with catheters. They can get clogged, they can get infected, causing sepsis, and they can also scar the veins inside your body. So there are several problems, but in this video, I'm going to be focusing on the problems related to the arteriovenous fistulas and the arteriovenous grafts. So both fistulas and grafts allow the blood to flow very fast during dialysis, but sometimes problems can develop. When they do, they need to be addressed quickly since you obviously need dialysis. So the first problem that can happen after installing a native arteriovenous fistula is a non-maturing fistula. And what that means is they put the fistula in, and usually it takes a few months for the fistula to be able to be used, but after, I don't know, 2, 3, 4 months, they are usually large enough that they can be accessed and they have enough flow. So there is a criteria to show that the fistula is able to be used, which is called the rule of sixes. And that means the vein needs to be larger than 6 millimeters. It needs to be no deeper than 6 millimeters from the skin. The vein needs to be superficial, and it needs to have more than 600 mL per minute of blood flow. When you meet all these criteria, then the fistula can be used for dialysis. But sometimes even after 4, 6 months, or even a year, that fistula is still not ready for dialysis. Then what can you do? So usually what happens is either the connection between the artery and the vein is too small, or at some point in the vein, there is some scar tissue or a narrowing in the vein that is preventing the blood flow to get high enough so the vein can dilate and be used for dialysis. And what can be done for that is we can do a procedure called a fistulogram, and that's when we inject dye into the dialysis access and we take pictures to see what's going on. And then we can not only take pictures, but sometimes when we find a problem, we can actually go in and dilate that fistula with a balloon, or even sometimes put a stent if a balloon fails. And you may require 1 or 2 procedures, but eventually, most of the time, we're able to get these fistulas to work and be used for dialysis so you can get your catheter removed. Another cause of non-maturing fistulas is if you have a bunch of side branches, then the blood flow is going through all these places and the fistula is not getting bigger. So what we can do in those cases, we can either ligate those side branches or we can put like little plugs on it so you can have more flow through the main conduit that we want to use for the dialysis. With the percutaneous fistulas that are done, sometimes one of the problems can be that the flow is going to the deep veins instead of going to the superficial veins. And there are ways that we can do to superficialize the flow, or sometimes block the flow through one of the deep veins so most of the flow can go superficial and be used for dialysis. So I would say if your dialysis fistula is not working after 3-4 months, you probably need a fistulogram to figure out what's going on, and most of the time we'll be able to do something to make it usable. Now, the second problem is low flows during dialysis. You may hear the nurse say like, oh, the machine's beeping because we can't get enough flow. So if you don't have enough flow, your blood cannot be cleaned up properly, or it may take a lot longer to do the dialysis. And we're talking here about patients that had a dialysis fistula or a graft, and they have been using for a while, but then all of a sudden the flows got slow. And that almost always means that there is a narrowing either at the connection of the artery to the vein or the graft, or somewhere where they are putting the needles. And remember, if you're putting needles for a long time in the same place, that could cause scarring of the vein as well. But the good thing is that we can almost always fix that. And the way we fix it is the same way we do a fistulogram, which is this study that we inject dye, and we find where the narrowing is, and we can open up, usually with a balloon, but sometimes we may need a stent. And these are all outpatient procedures that are done with minimal sedation, and you go home the same day, and you can use your dialysis exits almost right away after the procedure. We can measure the flow through the fistula or the graft with a simple ultrasound machine. And we usually do measure the flow before we do the procedure and after we do the procedure to make sure that we actually improve things. Now, the third problem that we're going to talk about is difficulty cannulating the access. Essentially, we're talking about an access that is hard to stick. So if this is a new access and the nurses are having a hard time, we have to check. First, we make sure that there is enough flow, that the vein is large enough, and that the vein is superficial enough. Sometimes one of the problems can be that the vein is too deep for them to access. In those cases, you can do a surgery to make a cut over the vein and then superficialize it. It's called superficialization. And that is a procedure that can work, but involves a large incision. What we've been doing sometimes is you can do a procedure called a lipectomy or liposuction, that we made tiny holes and we're able to either suck the fat over it or even remove the fat with an instrument to make the vein more superficial without requiring a bigger cut and recovery time. Now, the main issue with the cut for superficializing is like if you're already using the fistula, after the surgery, you have to stop using the fistula for a little bit until the surgery is healed. But if we do a lipectomy or liposuction, you may be able to use it right away. Now, if you've already been using for a long time the fistula, but now in the past few times the nurses have been trouble cannulating, almost always it means that you have some scar tissue in there or you are developing some clot inside the fistula that is making the needles not work as well. So in those cases, we need to go in and do a study, a fistulogram, and then fix the problem. If it's clot, we'll remove the clot. If it's a scar tissue, then we'll dilate with a balloon. Sometimes we use a balloon that is medicated that may last a little longer, maybe. And sometimes if the narrowing keeps happening very often, we may decide to put a stent. Another common problem that patients experience is bleeding after dialysis. As you know, the way you do dialysis, you put 2 needles into the dialysis access. And once you remove the needles, it can bleed for a couple of minutes and they hold pressure for a little bit, but it usually stops and it's not a problem. But what if they take a long time to stop, like nurses are holding pressure for like more than 10, 15, 20 minutes, even half an hour, or they were able to stop it, but when you go home, it starts bleeding again. That almost always means that there is a high pressure in that vein, and that's why it's bleeding so much. And the high pressure almost always means that there is a narrowing in the vein more distally to where they are putting the needle. So if you have a narrowing in the vein upstream, it's hard for the blood to get through that narrowing. That increases the pressure and makes it bleed. And that's usually scar tissue. And the way to fix it is, again, to take a picture, do a fistulogram, and then navigate to the area, get a wire across this area of narrowing, and then treat with a angioplasty, like with a balloon, or with placement of a stent if necessary, and then continue to use it normally. So it's important to know if you start getting more and more bleeding or it's taking longer after dialysis to stop the bleeding, you should go see an interventional radiology to get it checked before we have a bigger problem. Now, the 5th problem that we see sometimes is arm swelling. So patients are doing well, and then all of a sudden the arm blows up. it swells up. You can see the hand gets all swollen and puffy, and sometimes it may be difficult to even bend the elbow. So what causes that? As you know, there's a connection from the artery to the vein either in the wrist or in the upper arm here, and then the blood flow runs from the artery to the vein and then goes all the way down to the heart. The arm swelling develops when you have a narrowing due to scar tissue in the central veins. What are the central veins? The central veins are the veins inside your chest. They're large veins, and they are connecting the veins in the arm to the heart. And these veins sometimes can be narrow or sometimes can actually be completely occluded. Usually they get scar tissue in the central veins from prior dialysis catheters. And that's one of the reasons that we try to avoid having dialysis catheters in the patients. But sometimes they can happen even without a history of dialysis catheters. You may know this, but the veins normally don't have a lot of flow, as much flow as in patients that have a dialysis fistula. But once you have a dialysis fistula, you have a lot of flow that could long-term damage the veins. So the good news is we have a lot of tools nowadays to fix that. And depending on where the narrowing is, sometimes patients can even develop something called an SVC syndrome. SVC syndrome is when this main vein called the SVC gets blocked, and that prevents the blood return from both arms and from the head. So patients can develop face swelling, their face can blow up, their eyelids can blow up, they can get very swollen to the point that it may be difficult for patients even to open their eyes when they wake up in the morning. Then when they get up, it tends to get a little better since it facilitates the drainage from the face, but it's usually worse than early in the morning. That's called SVC syndrome, and it's very important to know if you develop any of those symptoms, you need to get it checked. Luckily, we have so many tools nowadays that we're almost always able to cross these occlusions and fix the veins. I would say over 99% of the time we can do that. And if we can't, then the treatment would be to actually ligate that access and terminate the access, because what's causing the swelling is actually the high flow going to the vein. So when you terminate the access, it tends to get better. But because we need the access and want to preserve, we try to fix the veins before we do that. Now, the sixth problem is called Steele syndrome. And what is the Steele syndrome? Steele syndrome usually happens in patients that have an upper arm fistula or an upper arm graft. And that's when the connection between the artery with the vein is too large, or patients have problems with blood flow going to the hand. And essentially what it is most of the blood flow is going through the fistula, and then not enough blood flow is going to the hands. And the way that this presents is usually patients have hand pain and hand numbness, sometimes gets worse while they're doing dialysis, sometimes can be unbearable. In the worst case scenarios, you may start developing some ulcers or thinning of the nails. So this is very important to diagnose so we can prevent any loss of tissue in the hand. The diagnosis usually is done with a fistulogram and a clinical examination. So usually you cannot feel a pulse down in the hand. The fingers look dusky. When we do the fistulogram, we see all the flow going through the fistula and not much blood flow going down the hand. Now, of course, in severe cases, if this happens, we just need to terminate the fistula. We just need to ligate them. But in some cases, if it's not that severe yet, if we can find out early enough, what we can do is a procedure called bending. That's a minimally invasive procedure that we do through two small, little holes. And we can basically put a stitch around the fistula to decrease the size of that connection between the artery and the vein. And that tends to be very helpful in improving the symptoms from Steele. Another way that you can treat that, especially in cases that patients already have a graft, is to increasing the length of the graft, making a straight graft, for example, into a looped graft. And that increases the resistance throughout the graft and makes it easier for the blood flow to go down the hand. And last but not least, the seventh problem that you can have with a dialysis access is a clotted access. And essentially that's when your fistula or graft suddenly stops working because clot forms on it. And this is called a clotting or a thrombosis. And if you go to dialysis to try to do dialysis, they are gonna tell you, well, this is clotted, we can even put a needle in there. And if you didn't realize, that the access clotted, you would go to dialysis and they would just feel it and maybe try to put a needle, and they would just tell you, well, it's clotted, we can't do dialysis. You have to see an interventional radiologist. So that's why it's important to learn how to feel your access or graft. So I recommend people feeling their graft and checking almost every day, because then they can realize that the graft is clotted or there is a problem even before they see an interventional radiologist. And of course, at that point, you can't do dialysis that day, then you need to go to the ER or call us, and you will likely need an emergency procedure within the next 1 to 2 days so you can have your regular scheduled dialysis. And luckily we can do that. There are several interventional techniques that we can use. We can either inject a medication called TPA, that is a clot buster that will help dissolve the clot. We have several different catheters that we can use and devices that can suck that clot out and open again. Now, most of the time when you have a clotted access, it happens because there is a narrowing that is decreasing the blood flow through the graft, and once it reaches a point that there's not a lot of blood flow, it makes it easier to clot. So almost always there is a narrowing in the graft that needs to be treated with either a balloon angioplasty or a stent, and we're prepared to do that when we see these patients. Sometimes when the graft is clotted, it's difficult to find out what exactly was the problem, and we may need to do a follow-up fistulogram, let's say in a few weeks after declotting it. But every case is different, and we'll let you know what the best course of action is. So another problem that can happen with grafts and fistulas is the formation of ulcers where they are putting the needles, especially if they're putting the needles always in the same place, or even an infection of the graft or the skin around it. And that can be very serious, and most of the time if an infection actually happens in a graft, then the graft will need to be removed and a new access will have to be created. The way you would know is you would see that your graft is getting red and sometimes painful, or sometimes you have a big scab over it, which is actually dangerous because if you have an ulcer and a scab, they could potentially also bleed. So if you have any of those, you should get it checked because something may need to be done. Sometimes the graft may need to be revised, or a new graft may need to be placed. Now, although there's nothing you really can do to prevent these things, it's important to know how to diagnose earlier so they can be treated before it becomes a bigger problem or an emergency. And that's why it's important to check your graft or your fistula almost every day and see how it feels. So normally you have a thrill over the fistula or the graft. So you feel like it's almost like a cat purring over it. And the thrill can be strong, but usually is constant. So if you're watching it and touching it every day, you will feel if the thrill gets more faint, or if you can't even feel the thrill, then it's a sign that it needs to get checked. So a faint thrill would indicate either a problem with the connection of the artery with the vein or the graft, or could indicate a narrowing in the area where they're putting the needles. Now, if you have a thrill and all looks good and all of a sudden that access becomes pulsatile instead and you lose the thrill, that usually indicates that you have a narrowing upstream, and then it gets pulsatile because it's having trouble going through the narrowing. And of course, if you can't feel anything, the odds are it's probably clotted and you need to see an interventional radiologist to get unclogged. So it's important not only to look or touch, make sure you don't have any ulcers over the access, make sure it doesn't look red, and make sure you keep the area clean. I also would recommend you to take ownership of your care and actually encourage the dialysis nurses to access different spots every time they do it, a little bit different, so they are not putting the needles always in the same place, because that can cause problems as well. So the good news is most problems can be easily diagnosed by a nephrologist or an interventional radiologist with a simple physical exam and maybe a bedside ultrasound that can help understand what's going on. So in summary, we understand that a dialysis access is your lifeline if you need dialysis. So I think it's very important to understand what problems can happen with them. How can you diagnose these problems yourself early so you can get the treatment you need and prevent problems? And if you think there's something different or something wrong, don't be afraid of talking to your interventional radiologist because he will likely be able to help you.